Dr. Sunil, please introduce yourself and go ahead with your case.
Yes, sir. Thank you very much, sir, for giving us opportunity to present my case here. Myself, Dr. Sunil Bobade. I did my DM from BJ Medical College, Ahmedabad, EL Mehta Institute, and now I am practicing at Bid, Maharashtra. So I am presenting CTO case of.
So you are in Gandhidham, right?
No, sir. I was in Gandham 1 year back at Sterling Hospital. Now I am practicing at Bid, Maharashtra, Bid district, Maharashtra.
Bid. So where is Bid for our knowledge, Sunil?
It's nearby Aurangabad and Pune.
Aurangabad and Pune. So it's in Maharashtra, right?
Yes, sir. Yes, sir.
Okay. Okay, please go ahead.
My case is a 65-year-old female patient presented with class 2 angina and dyspnea. She is known case of diabetic hypertension, echo suggestive of RWMA with EF of 40% around, with old QOs in 2-3 AVF, and angio suggestive of mid LED 90%, L6 80%, RCO mid CTO, which was filled with grade 3 collaterals from LED. And already I was taking DAPT, antiplatelets, and anti-diabetic. Her JCTO score was 0, syntax 1 is 19, 2 for PCI was 39 with 13% mortality for PCI, and for CABG it was 22. But patient had some mortality during post-CABG in one of his relatives, so he was reluctant to do for CABG and willing for angioplasty. So we planned for RCA CTO first. So this was the angio. You can see grade 3 collaterals feeding the RCA. It was short stump of the mid RCA CTO with RCA osteal lesion also there. So considering the short CTO length less than 20 mm, visible proximal cap, you can see there is tapered cap at the proximal. Distal vessel is also good. So we decided to go antegrade approach. And in this case, our plan was to go antegrade wire escalation first, then parallel wiring, and if required, ADR. So in wires we kept in backup. We started with Pillar XT, Miracle 3.6, and Gaia 2 and 3. And microcatheter was Caravel. So initially started with Pillar XT considering the micro channels, but Pillar XT failed to cross. So Pillar XT in cusp. They started with some more steeper wire, Miracle 3, which is hydrophobic and is good for control drilling. But we entered in false lumen, that is in extra plaque space. You can see clearly in 2 orthogonal views, the Miracle is in false lumen. So the next plan is to go use parallel wiring, keeping Miracle in place. We started with Gaia 2 and just rotating and adjusting the angle of the Gaia. We are able to cross the distal true lumen with Gaia, and which is confirmed with retrograde injection from the other side. You can see we entered successfully in the distal true lumen. So initially pre-dilated with one more balloon. As microcatheter was unable to cross, you see after serial pre-dilatation, the Caravel microcatheter crossed to distal lumen with balloon trapping technique. You can see that 2 by 12 mm balloon and the catheter. Microcatheter kept in place and wire exchange to routine workhorse wire. And after extending the wire to routine Sion blue, the lesion again pre-dilated with CTO balloon, then 2 by 8 mm semi-compliant, then NC balloon. And this was the distal stent. Distal stent was 3 mm and proximal 3.5. NC distally done with 3 by 12 mm and proximally 3.5 by 10 mm. So this was the result after post NC. There is some under expansion at proximally, but we don't have IVAS to measure them, and we accepted the result without any complication. There is T3 flow, no any digital dissection. So learning point for me in this case, pre-procedural planning is vital in CTO. Operators should have a blueprint of anti-grade wire installation. We use here Pillar XT, then Miracle 3 and Gaia 2, which is hydrophilic taper tip wire. So wire left in place, that is a parallel wire technique, act as a roadmap to success. It stabilizes the wire course, vessel course, and also gives the direction. So Pillar X is typically soft taper tip wire, which is used for control during loose tissue tracking and passive wire control. While Gaia family is for active wire control, which is for fibrocaspase, plaque tracking, intimal or subintimal. If a microcatheter doesn't advance over the wire, remove balloon trapping and use lowest profile balloon, followed by serial balloon dilatation. CT core registration or imaging would give better result. Choose your CTO lesion wisely. So early CTO 0 to 1, next J CTO 2, later 3. So this score was 0 in this case, and this was my first CTO case. I did successfully. Thank you, sir.
Very nice, Sunil. Very nice. So I feel literally it gives me a lot of pride to see that how our complex interventions are being done every nook and corner in the country. So this is such cases require good endeavor, good planning, and obviously some audacity to just plan out these cases and execute. So very well done.
Just keeping the algorithm in mind, I just followed the steps of the algorithm.
Very good, very good. So only thing is, we everybody should stick to basics. Always start CTO with a 5,000 heparin and keep the ACTs. Do not let the ACTs go very high. And then be very careful while you cross or advance the wire into the CTO segment. Keep looking for perforations. This case, I think there were hardly any bridging, but problem is where there are bridging collaterals, you can actually rupture some of the bridging collaterals, which can bleed. So be very careful. But then all these techniques, the parallel wire technique, if keep looking at all the different projections while your wire is getting advanced. In one projection, you may be having a feeling that you are going into the true lumen, but other projection tells you that it's in a false track, then do not advance. But however, if you are carried away and keep advancing, then you call for a trouble. So with every inch of wire advancing into the CTO segment, keep checking the various projections.
Yes.
2 for sure, and at times 3 also. So this is my advice to everybody who are trying these complex CTOs. But very well done in the end. But yes, one thing more, I think Gaia is a very nice wire.
Yes.
I am fond of Gaia much over and above the Miracle wires. So maybe the first choice can be Gaia.
Yes.
That tip curve is very helpful, which is not there. Now, it's difficult to create such a tip curve with other wires. The Miracle wires or the Conquest wires, it's difficult to create. Now, what happens if the CTO is on the curve? Your CTO was on the curve.
Yes.
So, any hard wire has a tendency to go straight, right? So, it will miss out. It will create a false tune. But Gaia, you can manipulate with that tip curve and be very careful. So, but still, I think in the end, very well done. And then you fix the left side also?
Yeah, yes. In stage restoration after 1 month, we also put the left sides.
Okay, we'll have a word from Karan and then I think we can go ahead. Karan?
Yes, sir. Sir, you correctly emphasized that the Gaia wire is a great wire. One more important thing about Gaia is that there is 1:1 torqueability. So the minute you torque a little also, it torques as much as you want it. So that's why it is a great CTO wire, sir. Very well done case, sir.
Gaia is one wire which remains totally in your control.
Yes.
Yes, sir.
The control is with you. It's not there in Conquest. But at times, we require extra power or extra hardness of wires to penetrate into that cap with the CTO. So we use Conquest once the Gaia fails. So then we create some penetration into that cap. And if once we move slightly ahead, we take back the conquest and then go with the Gaia again into that passage and then keep probing. So this is what we do, and our success rate is very high with the CTOs. And but Sunil, it was a wonderful case done.
Sir, again, just for knowledge, I am asking as your experience. So in this case, RCO CTO was filled by grade 3 collateral from LED. LED was also 90% vision. So, like ideally, we should fix LED first, or should go for a CTO?
No, this is the absolute right approach which you have done.
Yes.
The vessel which is getting collaterals from the other vessel should be attempted first.
Yes.
Because suppose you start with LED and something happens with that LED, some slow flow or something, you are in big trouble. Patient will crash on table.
Yes.
This is the best. Now, once you attempt LED, you are much safer. You have already revasked the RCA. The reserves would be much better and you will be much safer. This is the way. And suppose you do not open the RCA, again push the patient for surgery. Suppose you fail, once again counsel the patient for surgery. If they're still okay and understand that doing the left system will be the partial revask, then okay, get it written on the file and you can attempt it. But it's risky to deal with the left system and not to do while you haven't done the RCA.
Okay. Thank you.
Thank you.